Good evening. Kindly confirm if I'm audible.
Yes, you're audible, Doc. You can proceed.
Okay, thank you. So good evening. I would like to welcome you all to today's webinar. My name is Dr. Priska Amolo. I'm a pediatrician and endocrinologist at Kenyatta National Hospital, and I'll be the moderator for this session. Our topic for today is diabetic ketoacidosis in children. And this is the third among a series of pediatric diabetes webinars, which will run until World Diabetes Day on 14th of November. The theme for this year's World Diabetes Day is access to diabetes care. Our speaker today is Dr. Winnie Saumu, who is a consultant pediatric endocrinologist at Chuka County Referral Hospital. Dr. Saumu has recently completed her fellowship and is awaiting graduation. So she did her fellowship in the Pediatric and Adolescent Diabetes and Endocrinology Fellowship Program at the University of Nairobi under the Kenya Pediatric Fellowship Program. She has a great interest in research and has several publications. Later on, we will also be joined in the panel by Dr. Hiwot Nida, a consultant pediatrician from Ethiopia, who is currently a fellow in the Endocrinology Fellowship Program at the University of Nairobi. We will have a question and answer session at the end of the presentation, so please send in your questions through the Q&A box. Welcome, Dr. Saumu.
Thank you, Dr. Priska, for that, for your kind words and that great introduction. So welcome everyone today. We are going to discuss diabetic ketoacidosis, and this is a follow-up webinar after what Dr. Phoebe Wamalwa took us through, that is Introduction to Diabetes. So we all know that one of the acute complications, and actually the commonest complication of acute complication of type 1 diabetes in children is diabetic ketoacidosis. So we'll go through an introduction. We'll look at risk factors for the diabetic ketoacidosis, pathophysiology, clinical features, and diagnosis, and then management. And then as we discuss management, we will be doing practicals, because the aim of this webinar is to make it easy for everybody to be able to manage any child who presents with diabetes ketoacidosis. So diabetic ketoacidosis is a major life-threatening complication of diabetes that is usually characterized by hyperglycemia, that is blood glucose level that is more than 11 millimoles per liter, ketosis, blood beta hydroxybutyrate that is more than 3 millimoles per liter, or in centers, most of our centers, especially in the counties, we are not able to do blood beta hydroxybutyrate. So we are able to do urine ketones, and usually you have moderate or large ketonuria, which is usually equivalent to 2+, more than 2+ of ketones on the urine dipstick. And then the other characteristic is acidosis. So a venous pH that is less than 7.3, or bicarbonate that is less than 18 millimoles per liter. So on the point of acidosis, there has been a change in the guideline. I think for those of us who have been managing children with diabetic ketoacidosis, the cutoff was initially 15 less than 15 millimoles per liter. But now it has been revised upwards to less than 18 millimoles per liter so that we can capture these patients early. And of note is that diabetic ketoacidosis is more common in type 1 diabetes mellitus as opposed to type 2 diabetes mellitus. And I think Dr. Phoebe really took us through the pathophysiology of type 1 diabetes mellitus. So the diabetes ketoacidosis usually develops when insulin levels are insufficient to meet the body's metabolic requirements. And insulin deficiency can either be absolute or relative deficiency. Absolute deficiency is, remember from the pathophysiology of the, type 1 diabetes, Dr. Phoebe told us that there's usually destruction of the beta pancreatic cells. And mostly in type 1, we have autoimmune destruction of these cells. And this can actually lead to absolute insulin deficiency. We can also, and that is especially in patients who are newly diagnosed. For patients who are already diagnosed and they are on follow-up and on exogenous insulin, in case they miss the dose of their insulin, they can actually go into DKA. Then it can also be due to a relative insulin deficiency, whereby usual insulin doses do not meet the metabolic needs, especially during physiologic stress conditions. For example, if you have a child who has diabetes and they develop infections, they develop trauma, and they are on treatment, maybe they are on glucocorticoids, this might actually cause a relative insulin deficiency, leading to a DKA. And this deficiency is usually accompanied by increase in counter-regulatory hormones. So the body tries to compensate by increasing the glucagon, cortisol, growth hormone, and epinephrine. And this type of imbalance will enhance hepatic gluconeogenesis, glycogenolysis, and lipolysis. I will explain further what that means. And most of the time, especially in our adolescent children, DKA without a preceding febrile illness or gastroenteritis that we see commonly among children who are less than 5 years, in a patient who is known to have diabetes is almost always the result of psychosocial problems and failure to appropriately administer insulin. So in terms of classification, we classify DKA based on the venous pH and the bicarbonate level. So we have mild, moderate, and severe. So mild DKA is when you have venous pH of less than 7.3 and bicarbonate that is less than 18. And I repeat, we have revised the guideline from 15 to less than 18 so that we can capture these patients early. Then moderate, less than 7.2 and bicarbonate of less than 10. Severe, if the venous pH is less than 7.1 and bicarbonate is less than 5. In terms of epidemiology, there's a wide geographic variation in the frequency of DKA at onset of diabetes. And in Europe and North America, the prevalence has been 15 to 70%. So it is quite common. And most of the time, it occurs at the time of diagnosis. And in Africa, it can go all the way to 95%. And studies have also shown that DKA at diagnosis is more common in younger children, especially those who are less than 2 years, because it is usually not very easy to pick features of diabetes in these children who are on diapers. And for the parents, it's usually difficult to even recognize that their child has diabetes or they are developing diabetes ketoacidosis. The risk of DKA is established type 1 diabetes is around 1 to 10% patient per year. DKA is one of the leading causes of mortality in children with diabetes. And worldwide, the mortality rate is at 0.15 to 0.30%. And in a study that was done in KNH and was published, this study was done by Musoma et al. And it was published in the Journal of Diabetes in 2020, whereby they did a retrospective study whereby they retrieved 159 files from of children aged 0 to 18 years admitted at KNH. And they found that the mortality rate was at 6.9%. And of note is that in this, they realized that they found that the cause of mortality was high mortality was more in children who had deranged UECs, especially those who had acute kidney injury at the time of admission, those who came with altered level of consciousness, like the ones who had low GCS levels, probably because maybe at the time they presented to the hospital, they already had features of cerebral edema. And 60 to 90% of deaths occur in association of cerebral edema. So the highest cause of mortality in patients who present with DKA is actually associated with cerebral edema. So it is always good as you manage your patients with DKA to watch out for cerebral edema. And this is the study I was talking about. And part of the faculty from the University of Nairobi were part of the study. I think I've already talked about that. So what are the risk factors for diabetes ketoacidosis? So in the newly diagnosed diabetics, young patients who are less than 2 years, they are more likely to have DKA because most of their symptoms at presentation may mimic many other childhood illnesses. Then in case of delayed diagnosis, in case it takes a while before the correct diagnosis is made, then risk of DKA would be very high. And this is very common in our setting because sometimes a patient is seen maybe at level 2 facility, and by the time they are getting maybe to a level 4, and the diagnosis of diabetes is made, or DKA of diabetes is made, it is already too late and they have already developed diabetes ketoacidosis. Those of lower socioeconomic status, because of they are less likely, the health-seeking behavior will be quite different because they are financially constrained. Countries with low prevalence of type 1 diabetes. So if you're in a country where prevalence of type 1 diabetes is low, it is very unlikely for you to think about diabetes when you get a child who has maybe, let's say, polyuria. You may think this could be due to a UTI. For example, if you are in Kisumu and you get a child presenting with high fevers, convulsions, you are more likely to think of cerebral malaria. But if you are in a place like Meru or Tharaka Nithi, it will be like your 4th or 5th differential diagnosis. So same case applies to diabetes. In countries where there's low prevalence, it's less likely to pick it early. Then in patients who are already non-diabetics, insulin omission is a risk factor. Patients who have poor metabolic control. That means they are more likely to be missing most of the doses, and so they are at higher risk. Previous DKA episodes, patients who have acute GE with persistent vomiting and inability to maintain hydration, and also peripubertal and adolescent girls, because during adolescence, there's usually a surge in sex hormones and also growth hormone that usually puts these adolescents in a state of some degree of insulin insensitivity. And this is what triggers DKA. And also limited access to health services. For patients who are on insulin pumps, as Dr. Laigong took us through the different modalities of delivering insulin. In some countries, insulin pumps are used. In Kenya, we are also having some patients who are on insulin pumps. And if the insulin pump system fails, these patients are more likely to get DKA. And also the other risk factor, especially in adolescents, is binge alcohol consumption. The precipitating factors for DKA. So anything that will cause increase in counter-regulatory hormones, infection or stress, any situation that will increase stress levels in the body. So infection, ischemia or infarction, glucocorticoids, inflammation like pancreatitis, major surgeries, and also missed insulin. So this is just a recap of what Phoebe took you through. I know we are privileged to have all the cadres joining us for this CMEs from the nursing team, clinical officers, medical officers, specialists, and now the subspecialists. So we are privileged, and I just want to recap what Phoebe took us through so that we know how type 1 diabetes occurs. And as I discussed that, I will be touching on the pathophysiology of diabetic ketoacidosis. So when you look at this diagram, which is a very nice diagram that I borrowed from Dr. Priska. Usually when we take food, it is usually converted into glucose. And this glucose usually enters our blood system. So it enters the blood vessel. And then from the blood vessel, it's supposed to enter the cell so that it can enable the cell to get energy and be able to function. So glucose is usually the main source of energy for cells. And how does glucose enter the cell? So for glucose to enter the cell, you need insulin. Without insulin, glucose will not be able to enter the cell. So insulin is usually produced by the pancreatic beta cells. Once it is produced, when you look at this diagram, insulin will act as the key that opens the lock that unlocks the pathway to get glucose into the cell. So you have these keys, you have these round things here, they are the glucose. So they are waiting for this padlock to open the door into the cell so that glucose can get into the cell and give it energy. So now in patients who have type 1 diabetes, there's usually too little insulin or no insulin at all coming from the pancreas. So meaning the keys are very few or there are no keys at all. And the door into the door that opens into the cell remains closed because the key, the insulin, is not there. So the padlocks cannot open. Therefore, the glucose will just remain in the bloodstream. And that's how we get hyperglycemia. So in the blood, there's a lot of glucose. But in the cell is surrounded by very high levels of glucose, but it's not getting into the cell. So the cells are starved of glucose. And this is what leads to the patients being lethargic. Then as the glucose continues to accumulate in the cell, we know that once glucose gets into the blood system, it circulates through all the system. Once glucose gets into the blood vessel, it circulates throughout all the organs in the body. So the blood will also circulate through the kidneys. And we know usually in a normal setting where there's no diabetes, generally we know that kidneys usually reabsorb glucose, the proximal convoluted tubules. There's reabsorption of glucose. And if there's excess glucose in the blood vessel that exceeds what we call the renal threshold for glucose, and usually the cutoff is 10 millimoles per liter, glucose will be excreted in urine. So glucose usually, as it is being excreted in urine, it will also go with water and electrolytes. So at the same time, as you are losing the glucose, you will also be losing a lot of fluid. Water will follow and electrolytes will also follow. And this usually causes increased urine output. So these patients will have what we call polyuria. So they are producing a lot of urine. And in a child who is in a bigger child who is who has already toilet trained and doesn't bedwet, if you get enuresis, then that should be a red flag that possible diagnosis would be type 1 diabetes, and worse still, DKA. And then as they continue losing the water, these patients will develop dehydration and weight loss. And they will present with, they can present with all degrees of dehydration. So some of them may come in shock, although shock is not very common among DKA patients or type 1 diabetics. They rarely come in shock, but some of them, when there's a lot of delay, they might actually come in shock. And then because of the dehydration, it will trigger the thirst center. So these patients will have increased drinking. So mom or the parent will tell you that this child is taking a lot of water, what we call polydipsia. So because when you look at the cell, it appears sad. So you can see this emoji, the cell is happy because there's some glucose getting inside the cell and there's insulin. But now when there's no insulin going in, the cell is starved of glucose and energy. So it is very sad. And what happens is the body tries to look for other sources of energy for the cell. So there's breakdown of stores in the liver, muscle, and fat to produce more energy. And because of this catabolic state, these patients will have massive weight loss. So mom will tell you, my child was like 20 kilos, and now within the past 3 weeks, this child has lost almost 3 kilos. And because of breakdown of fat, there will be formation of ketones. So ketones are very common in type 1 diabetes, especially patients who are developing diabetes, ketoacidosis. But it's very rare in patients who have type 2 diabetes and occurs because of breakdown of fat. Usually it is life-threatening. And the signs and symptoms, these patients will have sweet smell on breath because of acetone, what we call acetone breath. Because of the accumulation of ketones and the acidosis, they will have vomiting, abdominal pain, and also they will present with what we call Kussmaul breathing, the rapid, deep acidotic breathing. And they may actually come in with altered level of consciousness. So this is a summary, just explaining what I've talked about. So I have absolute insulin deficiency, or you have relative insulin deficiency, leading to increase in the counter-regulatory hormones. So when that happens, because you don't have insulin, so insulin will not go into the cell. So there will be reduced glucose utilization into the cell. We said insulin usually is anabolic. So it usually, it tries to store things. When there's no insulin, there will be no storage. So there will be breakdown of everything. So with the reduced glucose utilization, as I showed you in the figures, in the cartoons that I was explaining, will lead to hyperglycemia. So there will be a lot of glucose circulating in the blood system. Then, because there's no insulin, there will be increased breakdown of proteins and decreased protein synthesis. And also there will be breakdown of glycogen. Remember, the cell is surrounded by a lot of glucose, but there's none that is entering the cell. So the body recognizes that there's no glucose, so it tries to compensate, and that's why there's breakdown of proteins and breakdown of glycogen and reduced glucose utilization. So what will happen? All this will lead to hyperglycemia. There will be a lot of glucose circulating within the blood system, and then this will lead to when it gets to the renal system, there will be osmotic diuresis, like loss of glucose through the urine after the renal threshold of 10 millimoles per liter has been exceeded. And water and electrolytes follow glucose. So there will be loss of water, there will be loss of electrolytes. So these patients will be very dehydrated. And because of this dehydration, there will be less perfusion of the peripheral tissues. And this will lead to lactic acidosis. Then the other thing that will happen is there will be breakdown of fats, what we call lipolysis. So there will be increased free fatty acids to the liver. So there will be free fatty acid oxidation, leading to formation of ketones. So there will be increased ketogenesis. So ketones usually increase post-acidity. So they usually reduce the pH in blood. So ketogenesis will cause acidosis. And the body will realize that and try to compensate. How will it try to compensate? By utilizing the bicarbonate to buffer. So bicarbonate that is in the body will be utilized to try and counteract the acidosis that is being caused by the ketones. And with time, there will be reduced alkali reserve. And that's why in DKA, we have reduced bicarbonate that is less than 18 millimoles per liter. And all this, the breakdown of fats will cause the ketoacidosis and worsening of the acidosis, thereby lowering the pH. So here, I just want to emphasize that despite these patients losing a lot of fluid through osmotic diuresis, some of them may actually maintain, most of them actually maintain their normal blood pressure or even have high blood pressure. And this is usually because one, there's elevated plasma catecholamine concentration. Remember, we've said you have low insulin, there's increase in counter-regulatory hormones, and one of them is catecholamine. And we know catecholamines can actually increase blood pressure. And increased release of, there's usually increased release of ADH in response to hyperosmolarity. Remember, there's a lot of glucose in blood circulating. So this increases the hyperosmolarity of the blood. What will happen? A signal will be sent to the brain to release antidiuretic hormone. What does antidiuretic hormone do? It usually increases reabsorption of water or fluid into our bodies. So through the vasopressin 1 and vasopressin 2 receptors, and this can actually maintain the blood pressure. And then the increased osmotic pressure from the marked hyperglycemia actually is able to maintain the oncotic pressure within the blood vessels. And that is how the blood pressure can be maintained as normal. So considerable urine output also persists because of glycosuria until extreme volume depletion leads to a critical decrease in renal blood flow and GFR. And by the time you are getting oliguria or renal impairment, it means that is a patient who is very sick. So the other pathophysiology we want to look at is potassium loss. We've said during the osmotic diuresis, you also lose electrolytes. And the main electrolyte that is lost is the potassium. So one, lack of insulin will lead to shift of potassium from the intracellular to the extracellular space. I hope that is clear. Remember, when we are correcting hyperkalemia, we usually give insulin. The reason we give insulin is because we want potassium to go into the cell so that we can correct the hyperkalemia. So when you lack insulin, there will be a shift of potassium from the intracellular to the extracellular space. And then we've said that these patients are acidotic because of the ketones. Also, those who have severe dehydration, there's lactic acidosis, and all this causes severe acidosis. And when there's acidosis, there's extracellular accumulation of hydrogen ions. So there will be exchange of hydrogen ions and potassium ions. So hydrogen ions will go into the cell, potassium ions out of the cell. So from the intracellular space to the extracellular space. And this will lead to, eventually will lead to osmotic diuresis and hypokalemia. And vomiting. Remember these patients, when they have ketoacidosis, they present with vomiting. So as they vomit, they will have hypokalemia. And then these patients, because of osmotic diuresis, they get dehydration. So when there's dehydration, there's decrease in intravascular volume. And this usually triggers the renin, angiotensin, aldosterone system. And we know that And this, we know that increase in aldosterone will lead to loss of potassium in urine, what we call the kaliuretic effect of hyperaldosteronism. And then the other thing to watch out for is during treatment for DKA, once you start management of DKA and you initiate insulin, usually there's shift of potassium from the extracellular space into the intracellular space, and this also gives hypokalemia. So serum potassium levels may be low, normal, or high, even when the total body potassium is depleted. So this is very important. Always remember that these patients, they have their potassium depleted generally, even if you do the test and you find that their potassium levels are high. What about sodium? So the serum sodium usually is low, and this is usually due to the effect of the hyperglycemia. So usually for each 100 milligram per deciliter of glucose, the serum sodium level is lowered by 1.6 milli equivalent per liter. And when glucose levels start falling during treatment, the serum sodium level rises by the same amount. So when you do your UECs and find that the sodium level is low, you need to do a calculation and get the corrected sodium level, and that will give you the correct sodium level for that patient. So this is more of an emphasis, the clinical manifestations of ketoacidosis. So you have dehydration and electrolyte imbalance, hyperglycemia leading to osmotic diuresis and dehydration, patient presenting with polydipsia, polyuria, and there is loss of electrolytes. And because of this dehydration, how will the patient present? So some of them will present in shock. So features of shock, they will have a reduced, cold peripheries and weak or absent pulses. They will have cup refill time that is more than 3 seconds. Altered consciousness, or ABP will be less than A, and basically cold extremities. Then there are other dehydration signs: dry mucous membrane, sunken eyes, absent tears, weak, and cool extremities I've already talked about. But some of these signs are not usually, they are not objective. You can say they are more subjective. And then once you assess your patient, you usually, in diabetes ketoacidosis, think of their degree of dehydration in terms of percentages. So we usually say if they have severe dehydration or they're in shock, assume that they have greater than or equal to 10% dehydration. So those are the ones who have features of shock, the ones I've told you about. Then patients with DKA usually have a deficit in extracellular fluid volume that is usually in the range of 5 to 10% of body weight. And in terms of grading the degree of dehydration, so 10% is a patient who is in shock or has severe dehydration or shock. Then, or those who have severe DKA, you assume 10% dehydration. Those who have moderate DKA, you assume averagely 7% dehydration, and those who have mild dehydration, 5% dehydration. But in our setting, most of our patients actually come very late, and most of the time when you are not very sure, always assume 10% dehydration. This is a table showing the average losses of electrolytes per kg. So nausea and vomiting and abdominal pain. So nausea and vomiting are mainly due to ketosis. Abdominal pain can occur due to paralytic ileus that is caused by acidosis and electrolyte abnormalities. When you have hypokalemia, you get paralytic ileus that will cause abdominal pain and a lot of vomiting. And these patients may actually present eventually with confusion, drowsiness, and progressive loss of consciousness. Tachypnea and Kussmaul respiration happens usually to get rid of the extra acid by rapidly breathing out carbon dioxide. Acetone is usually highly fat-soluble ketone body and is excreted slowly via the lungs. And it generates an aromatic smell on the breath of patients with DKA, and this is what gives you the acetone breath. So I hope we are clear with the pathophysiology, but in case it's not clear, feel free to ask at the end of this. So diagnosis studies in DKA. So when you talk of DKA, think of the synonym DKA. D standing for diabetes. So DKA, diabetes, K, ketosis, A, acidosis. So diabetes. So I need to know what is the serum, what is the glucose level of this patient. So you must establish whether this patient is diabetic or not. So you do a serum glucose level, or you do a point of care glucose level using a glucometer. So if you find that your glucose level is more than 11 millimoles per liter or 11.1 millimoles per liter, then that patient has diabetes and might be having DKA. The second criteria that is required is K. K for ketosis. So always remember you have to check the patient's blood ketones or urine ketones. And for the blood ketones, we are looking at the serum ketones. I think Phoebe explained this, the beta hydroxybutyrate. And if it is more than or equal to 3 millimoles per liter, then there is DKA. Moderate or large ketonuria. So if you have more than or equal to 2+ on urine dipstick, then think of possible diabetes ketoacidosis. Then you do a blood gas analysis. Venous pH of less than 7.3 with a serum bicarbonate of less than 18 millimoles per liter. I know in most of our county referral hospitals, we are not able to do the blood gas analysis, but we shall, I think if in a county referral hospital, you're able to check your serum glucose levels, blood, urine ketones, and your patient is presenting with the classical features of diabetes, then you can treat as diabetic ketoacidosis. The other tests you do, UECs, because remember we said that there's loss of electrolytes, ECG to monitor for hyper or hypokalemia, and other tests are septic screen, and other tests are based on clinical findings. So ECG findings, hypokalemia, you have prolongation of the PR interval, T wave flattening, ST depression, or prominent U waves. We are more likely to get hypokalemia than hyperkalemia, but sometimes they have hyperkalemia, especially if they have renal issues. So let's go to management. So having understood the pathophysiology, let's look at the goals of treatment. So the therapeutic goals of DKA management include: 1, optimization of volume status. They have lost a lot of fluid. We need to replace that fluid. 2, correction of hyperglycemia and ketoacidosis. And usually we achieve this by insulin therapy. 3, correction of electrolyte abnormalities. And 4, management of potential precipitating factors, and also prevention and treatment of complications of DKA treatment. So during your initial assessment, you've gotten your patient, maybe a child who is 3 years, presenting with the classical features of diabetes. So from the short history, you realize this patient actually has polyuria, polydipsia, lethargy, vomiting, confusion, abdominal pain. Mom says there's weight loss. And for a non-diabetic patient, they say the last time they took their dose was like 3 or 5 days ago. And maybe the child is presenting also with very high fevers, difficulty in swallowing, that would point towards maybe an infection, upper respiratory tract infection. So you have that at the back of your mind. So you need to assess for a degree of dehydration. So we assess the same way as we assess the other children. So shock symptoms are the same. Severe dehydration, some dehydration, no dehydration. But in children with severe DKA, we assume 10% dehydration. Those with moderate DKA, we assume 7% dehydration, and those with mild DKA, 5% dehydration. So, so you've done your history and you assess severity of dehydration. So, depending on how sick your child is, you may decide. If the child is very sick, you may go straight to EPLS protocol. So the airway, you need to look look into the airway and position the airway. Head tilt, chin lift maneuver, the same protocol we use for ETAT. Check for patency. If there is a problem, intervene. In B, you check if you give oxygen to patients with circulatory impairment or shock, severe circulatory impairment, or those are in shock. And intubation should be avoided as much as possible, because research has shown that patients who are intubated because of blowing out the CO2, they are at risk of getting cerebral edema during treatment for DKA. So unless it is very necessary, because there are some patients we must intubate, but usually we do that in consultation with the critical care team. Then in circulation, you need to obtain to insert 2 large bore cannulas. And if that is not possible, you can do intraosseous access. And as you do this, now you take samples for all the tests that you need. So you've checked your blood glucose, you can take samples for HbA1c, urea, electrolytes, and creatinine, full hemogram, and any other test that you may need to do. And at the same time, you've catheterized. If it's a patient who is unconscious, catheterize and get a sample for urine to confirm whether we are in DKA or not. And if it's a patient who can pass urine, you get a sample and you do a urine dipstick to check for ketones. If you're in a center where you're able to do blood ketone levels, you also do that. So now, in circulation, if your patient is in shock, you need to resuscitate your patient and get them out of shock. And we usually give 20 ml per kg bolus over 20 to 30 minutes. This also is a new change in the new guideline, 20 ml per kg over 20 to 30 minutes. So meaning the same way we manage shock in other children is the same way we will manage this child. And you're allowed to repeat your bolus, but do not exceed 40 ml per kg in the initial 4 hours. And if your child is not in shock, then you can give 10 ml per kg over over 1 hour. And you repeat your bolus until perfusion improves. I hope that is clear, but we will do practical bit. Then, so for correction of, so you also need to correct the deficit. So you need to calculate the, you need to calculate the maintenance fluid plus deficit, because after the first 1 hour, after resuscitation, you need to maintain this patient on fluids. And usually we usually calculate the maintenance using the normal formula for maintenance for children. And then you, if your patient is in shock, 10%, you calculate fluid that is equivalent to 10% dehydration and add it to the maintenance, and you correct that over 48 hours. And so your choice of fluid is either normal saline or reverse lactate. And once your blood glucose level is between 14 to 17, you need to use a fluid that has dextrose to avoid hypoglycemia. And then if there's no IV or intraosseous access that is available, you can actually rehydrate orally or by NGT with ORS. That is in centers where they are resource limited. So just an example of how to calculate this. So a child who is 20 kgs with 10% dehydration, how much fluid would be given to correct the deficit? So 10% dehydration. So usually you take the percentage of dehydration multiplied by 10, multiplied by the weight. So this will be 10 times 10. So that will be 100. 100 multiplied by 20 kilograms. So for this child, the deficit will be 2,000 mLs. And this should usually be corrected over 48 hours. So example 2, a child who is 10 kgs, 10% dehydration. So it will be 10 times 10, 10 times 10 times 10. So it will be 1,000 mLs of IV fluids. Then calculation of maintenance fluid, we just do it the same way we do for the other pediatric patients. First 10 kgs, 100 mLs per kg, next 50 mLs per kg, and weight above 20 mLs per kg. And for this patient now, the first 10 kgs, it will be 100 times 10, and then the next 10 will be 10 times 50. So that will be 1,500 in 24 hours. Then now we calculate the whole amount of fluid that is needed over 24 hours. So the same child, 8-year-old, 20 kgs, random blood sugar of 28, and urine ketones of plus 3+ with 10% dehydration. So resuscitation fluid was 20 times 20. That was given over the first 20-30 minutes. And the deficit over 48 hours is 10 times 20 times 10. I hope that is clear, 2,000. And then maintenance fluid, just for 24 hours will be 1,500, but for 48 hours will be 3,000. So the total fluid will be 2,000 plus 3,000, which is 5,000. But in the initially, in the previous guideline, we were not subtracting the initial resuscitation fluid, but now there's a recommendation that it's good to subtract the initial resuscitation fluid. That is, so you have to remove the resuscitation fluid that was 400 mils, and that will give you 4,600 mils in 48 hours. Therefore, your hourly rate for the next 48 hours will be 4,600 divided by 48, which comes to 96 mils per hour. And if you are using a Soluset, you are able to calculate in drops per minute. So this translates to 96 drops per minute. And if you are in a well-resourced center, you are supposed to use infusion pumps. So after 7 hours, the random blood sugar of this child drops to 13 millimoles per liter. So what will you do? So remember, our choice of fluid was normosaline or Ringer's lactate. But once the blood sugar level drops to less than 14 to 17, you can choose any of the figures. You need to switch your choice of fluid. And even as you are giving instructions, it has to be very clear because there is a high risk of going into hypoglycemia. And these charts, if you are not able to calculate, you can actually use these charts that are provided in the pediatric protocol. So the second step is insulin therapy. And we usually need insulin because we need to restore normal cellular metabolism, to suppress the lipolysis and ketogenesis, and to normalize blood glucose concentration. And for insulin, we usually start rapid or short-acting insulin via infusion pump. That is what is recommended at least 1 hour after starting fluid replacement therapy. So let me repeat that. You only start insulin from the second hour. Always remember, first hour, you are resuscitating, fluid resuscitation. From the second hour, you start insulin infusion. And this is very important because if you start insulin early, there is high risk of getting cerebral edema. And the dose, for those who are less than 5 years, 0.05 units per kg per hour. Those who are more than 5 years, 0.1 unit per kg per hour. And if you are in a center where the infusion pump is not available, do not fret. You can still be able to manage these patients in your centers. So you can take, like for a 30 kg child, if you put 30 units of insulin in 100 ml of saline and run at 10 ml per hour, that would administer 0.1 unit per kg per hour. If you give that at 5 ml per hour, it will administer 0.05 units per kg per hour. The other way is you can actually take an equal dose of like 50 units of insulin, add 50 units of normal saline or water for injection, such that you have 1-to-1 dilution of the insulin. And that way it will be very easy for the person who is managing this child to calculate the dose. Target blood sugar fall at maximum should be at 5 millimoles per liter. And if a more rapid fall, then you need to switch to 5% dextrose. And you may increase the glucose concentration up to a maximum of 12.5% if you're using a peripheral line. And in case of hypoglycemia, you manage it as the way we manage other children, 5 ml per kg, 10% dextrose, bolus, unless it's a neonate. Once DKA is resolved, you switch to subcutaneous insulin, and the dose is usually for prepubertal 0.5 to 1 unit per kg per day, pubertal 1 to 2 kilograms per kg, units per kg per day. So in circumstances where continuous IV administration of insulin is not possible, in patients with mild to moderate DKA, you can actually use subcutaneous insulin. And hourly to 2-hourly subcutaneous rapid-acting insulin analog is safe and may be as effective as IV regular insulin infusion. And the dose is usually 0.15 units per kg every 2 hours and should be initiated 1 hour after the start of fluid replacement. And you reduce to 0.1 unit per kg every 2 hours if the blood glucose continues to decrease by greater than 5 millimoles per liter. If you are in a center where you're not even able to access rapid-acting insulin analog, you can still use regular insulin subcutaneous every 4 hours. And the dose is 0.13 to 0.17 units per kg per dose of regular insulin every 4 hours. And the dose can be increased or decreased by 10 to 20% based on your blood glucose levels. So you can go up or down. So in terms of transitioning to subcutaneous insulin, oral fluid should be introduced only when substantial clinical improvement has occurred. There's mild ketosis and acidosis. In most cases, there could still be some mild ketosis. And when ketoacidosis has resolved and oral intake is well tolerated, the change to subcutaneous insulin can be done. And usually, from Dr. Laigong's lecture, we talked about the type of insulin we put these patients on. So you can transition to pre-meal rapid acting or regular insulin and basal insulin. So for basal insulin, you can choose the intermediate acting or the long acting based on availability. Intermediate acting is something like NPH. Long acting is something like Lantus. Rapid acting, something like Novorapid. Regular insulin, something like what we have in the counties, Actrapid insulin. So when you are transitioning, so this patient has been on an infusion. So the first subcutaneous injection should be given 15 to 30 minutes. If you are transitioning using rapid acting insulin, or 30 minutes to 1 hour if you are using regular insulin before stopping the insulin infusion. So your instructions will be, so during the next meal, we are going to transition this patient. So 15, if I'm using, let me use what we, regular insulin, it is what is more common. So 30 minutes before stopping the insulin infusion, you give your injection of regular insulin. Then 30 minutes later, you are supposed to stop the insulin infusion, and it usually coincides with the time the patient is supposed to feed. So you will say when you are starting 30 minutes after you are given the injection, we stop the insulin infusion and then you feed. If you are transitioning using the long-acting insulin, the overlap between the infusion and the dose of maybe Lantus should be at least 2 hours, because we know it takes more than 2 hours for it to onset of action to set in. Then insulin calculation. I just want us to calculate for this child, the same child. So we said that if the child is more than 5 years, it's 0.1 unit per kg per hour. Our child is 8 years. So it will be 0.1 unit per kg per hour. So the T-sheet will read like 2 unit insulin, 2 unit per kg per hour. And how will we transition this patient after DKA? So this child is 20 kilos and is prepubertal. Let me go to this. So the child is prepubertal, 20 kgs prepubertal. So we can actually decide to do at 0.05 units per kg per day. If it is a pubertal child, then you can start at 1 unit per kg per day. So this is an example, a 50 kg pubertal child, 1 unit per kg per day as insulin dose. Transition is you divide it 50-50 or 30-70 if you're using basal versus soluble. If rapid acting, you give rapid acting 50% of the dose as rapid acting and 50% as basal. Then if you're using soluble, 70% as soluble and 30% as basal. For potassium, if the patient is hypokalemic, you may need to start a replacement at the time of initial volume expansion or resuscitation by giving 20 millimoles per every liter of fluid that is given. If they are normokalemic, you start replacing after the first 1 hour, and usually you will give 40 millimoles or milliequivalents of potassium chloride for every liter of fluid that is given. If they are hyperkalemic, you wait until urine output is documented, and then you monitor your potassium levels at least every 2 to 4 hours. And once a patient is taken orally and they are still getting hypokalemia, you are actually allowed to give oral potassium chloride at 1 to 4 millimoles per kg with feeds in 4 divided doses if the patient is taken orally. Then do we correct acidosis? Correction is not recommended. So we usually don't recommend giving bicarbonate unless the patient has severe acidosis. And most of the time, this is done by the ICU team. And if there is life-threatening hyperkalemia. And patients who have severe DKA, severe and moderate DKA, ideally should be should be managed in an ICU or HDU setting. So one of the complications is cerebral edema. And what are the risk factors? So early IV insulin infusion, or if you give a bolus of insulin, IV, use of bicarbonate, those who are less than 5 years, those who have severe acidosis, and those who have high initial serum urea, and patients who have really delayed before presenting themselves to the hospital, and most patients with new onset diabetes, because it takes a while to diagnose them, they are more likely to get the cerebral edema. So the rapidly rising intracranial pressure may present as headache, vomiting, slowing of heart rate. They have change in neurological status, and they may actually have cranial nerve pulses, decorticate or decerebrate posture, and decreased oxygen saturation. How do you manage them? So if you suspect cerebral edema, you have to treat it urgently, and you exclude hypoglycemia as the cause of change in neurological state. So you reduce the rate of fluid administration by 1/3. You give mannitol 0.15 to 1 gram per kg over 10 to 15 minutes, and then you can repeat after 30 minutes. Then the alternative is hypertonic saline, 2.5 to 5 ml per kg given over 10 to 15 minutes. And you can repeat also if there's no response. And you elevate the head of the bed. And for such patients, intubation may be necessary, especially those with impending respiratory failure. And always remember, patients who have altered consciousness, it is always good to do a brain CT scan, because they may actually be having intracerebral causes of neurological deterioration, especially thrombosis or hemorrhage. Remember, hyperglycemic state predisposes them to thrombosis. So CT scan, very important. These patients need to be monitored hourly. Monitor your heart rate, blood pressure, respirate, level of consciousness, and blood glucose. You monitor your blood, urine ketones at least every 4 hours. Record fluid intake, insulin therapy, urine output, and repeat your UECs every 4 hours. I already talked about transitioning. So in Kenyatta National Hospital, and this may be something that can be borrowed, in the counties and all our hospitals across the country, they have this chart where you are able now to know how often you are supposed to be monitoring the patient. And usually it improves the outcome of the patient, and you are also able to pick the ones who are going into cerebral edema. Yeah, these are just some of the formulas that we use, like the corrected serum sodium that I was talking about. And there's an algorithm on management of DKA. And I think this should be adopted. I think it's in the protocol, basically a summary of what I've talked about. Thank you.
Thank you, Dr. Saumo, for that very detailed and insightful update on diabetic ketoacidosis in children. I think we have all learned a lot, and I can see we have many questions coming in. So we will now move on to the Q&A session. Remember to post your questions in the Q&A box. So I'll start with the first 2 questions which are related. So the first one is Maurice Murithi, who is asking, elucidate a bit on euglycemic DKA. And related to that, Stephen Juma is asking, is it possible to have DKA with blood sugar levels less than 11 millimoles per liter? If so, what will guide your choice of fluid? Or at which point should we change to dextrose, half normal saline? Dr. Saumo?
Okay, yeah, so thank you for Yes, thank you for that question. Yes, it's possible for a patient to have euglycemic DKA, especially children. Especially it can occur actually in young children because of especially children who have gastroenteritis. So in such patients who are not taken orally well, it is possible to have the euglycemic DKA. So in terms of management, you will still manage them as DKA, but in terms of your fluid choice, you must ensure that there is some glucose in your remember we said if the blood sugar levels are less than 14 to 17, anything below that, you use a fluid that contains dextrose. So you can use actually DNS, or if the sugar levels is way below, like less than 10, you are still allowed to increase your concentration of dextrose up to 12.5% if you are using a peripheral line. But beyond 12.5%, you need to have a central line in situ.
Thank you. And maybe just to weigh in on that, other situations that you may get euglycemic ketoacidosis include patients who may be fasting or those who are on a ketogenic diet, so meaning they are taking very little carbohydrates. And also in pregnancy, you may get cases of euglycemic ketoacidosis. And in patients who are on certain oral hypoglycemic agents, it's also commonly seen.
Especially
okay, so yes.
Yeah, for the SGLT2 inhibitors, I think that is usually common among type 2 diabetics. So yes, so if they are on the SGLT2 inhibitors, they can actually get euglycemic ketoacidosis.
Yes, thank you. So the next question is, how are you able to ascertain the percentage of dehydration? And that's from an anonymous attendee. And Clement Luvinzu is asking, this is similar, how do you determine the percentage of dehydration that will aid you in calculating the amount of fluids to be given in DKA? Dr. Hiwot, would you like to take that?
Good evening. Thank you, Dr. Samu, for the excellent presentation. So to answer the question that has been raised, so how to know the degree of dehydration in these children is, one is the severity, because actually dehydration in DKA or diabetes is difficult to assess because of the osmolality is not that much affected. You may not find the typical dehydration symptoms, and if they have another associated problem, then that will be difficult. So will depend on the acidosis. One can also tell us the degree of dehydration. If it is severe DKA, that means the dehydration level is also the same as comparable with severe dehydration. So you consider if the pH is less than 7.1, then severe DKA, then you also consider the dehydration level to be the same, severe. Shock is difficult. It's not difficult. So the capillary refill will be very delayed, feeble pulse. And if the BP is dropped in oliguria, then that's the patient is in shock. You have to manage it as a shock. But for the dehydration, especially when the moderate and severe and mild dehydration, you have to rely on the state of acidosis, the bicarbonate level and the pH level, so that you can correlate the dehydration level with the state of acidosis. But again, you can also assess the dehydration as the other patients you assess for the dehydration, like acute gastroenteritis patients. So you have to always look for the capillary refill, the urine output, the pulse, and maybe the skin turgor might be difficult to assess for dehydration because of the osmolality, but you can use those parameters. Thank you.
Thank you. Yes.
And maybe to add on what Dr. Hewitt has said, I know in the peripheries, people might not have access, to doing BGS and all that. So it might be difficult for them to even do the assessment of the severity. So in such cases, remember the ETAT protocol where we have shock, we have severe dehydration, or we have moderate or no dehydration. So if you're in such a scenario, you can actually, for anyone who is in shock, you give them 10% dehydration. For someone who is severe, moderate, severe dehydration, you can give something like you can do the 7% dehydration, and then someone who has no signs of dehydration, you can give that 5% dehydration.
Thank you. Okay, so the next question is from Christopher Kinyungo, who is asking, in absence of normal saline, can Ringer's lactate still suffice for DKA? And Aswan Omondi is asking, can Ringer's lactate worsen acidosis, leaving normal saline as fluid of choice? Dr. Saumu?
Okay, so if you are in a facility where there is no normal saline, actually, you can be able to use Ringer's lactate. And also, the other scenario where you can switch to Ringer's lactate is when you have hyperchloremic metabolic acidosis, hyperchloremic metabolic acidosis, which usually arises when you've given so much normal saline such that this patient remains acidotic, but it's because of the hyperchloremia. So for such patients, you need to switch to Ringer's lactate. So the question is, the second question was if Ringer's lactate can worsen.
Yes, if Ringer's lactate worsen acidosis, leaving normal saline as fluid of choice?
Theoretically, yes, but because I think I wouldn't be worried about it worsening the acidosis. So I think it is safe to use. It is safe to use Ringer's lactate, especially if you're in a setting where you don't have access to normal saline.
Okay, and just to add, just as you've mentioned that you're likely to get hyperchloremic metabolic acidosis with normal saline, and remember that we're also giving them potassium chloride, yeah? So one way you can actually suspect hyperchloremic metabolic acidosis, if you have your UECs, you have your sodium and your chloride. If your chloride sodium ratio is more than 0.7, then that tells you that you most likely have hyperchloremic metabolic acidosis. But the good news is that it's usually self-limiting, so it's nothing to really get worried about. Okay, so Keljoy Mukuri asks, it's not clear how much dextrose you give if blood glucose is between 14 and 17. Dr. Hewitt?
Okay, this is for when after you start the management of DKA, the sugars become getting lower. So when the sugars become, the guidelines have different recommendations. So that's why I think Dr. Samo put 40 and 17. So when the sugars level, the RBAC is below 17 millimole per liter, then you shift the fluid you start with 5% dextrose. So you shift the fluid to 5% dextrose. And when the sugars falls below 14 millimole per liter, sometimes they also say 10 millimole per liter, you shift the fluid to 10% dextrose. I think this one is clear.
Okay, thank you. Leah Okode says, hi, is management of DKA the same even in children with severe acute malnutrition? Dr. Saumu?
Thank you, Leah, for that question. So a patient with severe malnutrition, I think the management would still be the same.
Yes.
There's no different protocol for a patient who has severe acute malnutrition. But maybe we know that in patients with severe acute malnutrition, usually the rate of fluid, if you give your fluids very fast, you may actually cause decompensation. So maybe for such a patient, you may need to be very keen on how fast you run your fluids. So for example, we know that in acute malnutrition, we usually give our initial bolus of I think, is it 2 hours? Yes, over 2 hours. So if you are very worried about this child going into decompensation, you may actually give the fluids, same protocol, but you run your fluids slower as per the guideline for the children with malnutrition. Maybe Hewat can add, or Priska.
Okay, thank you, Dr. Saumu. I agree with you. So the management, there is no different management for patients with acute malnutrition, but we should be very cautious when we are giving the fluid. That's the problem with the malnourished patient. So they can develop fluid overload. So as much as possible, let's use the lower dose of the total amount of insulin we are calculated, then follow any signs of fluid overload. But there is no difference in the management of the patients with DKA with malnutrition.
Thank you. I think that is clear. So Dr. Msuo Omar says, hello, should the patient be nil per oral during DKA? Dr. Hewat?
Yes, there should be NPO, especially in the first, if they're present with severe DKA, they should be put on NPO because they will have severe abdominal pain, nausea, and vomiting. So that will worsen the acidotic condition until the patient is able to feed. We start with, even when we replace, Dr. Saum has discussed about transitioning. So when we transition, we also start the pure feeding. So we start with very slight food or fruit diets. Then as the patient is tolerating, we'll shift to a solid diet. So of course, we need to put the patient in PO. Thank you.
Okay, thank you. Wow, the questions are very many. I don't think we'll be able to answer all of them. Let me just take a couple more questions. So in desperate, someone is asking, please expound on fluid therapy. That's quite a lot, but maybe you can summarize and then also talk about phosphate replacement. Dr. Omar Msuo is asking about that. Dr. Saumu?
Okay. So fluid, let me just open that slide on the same. So for fluid replacement, can you see the screen?
Yes, we can see it.
Okay. So for fluid replacement, basically you start with resuscitation. So if the patient is in shock, you give resuscitation fluid that is, can you see the screen or it has disappeared?
It says it's at the end of the slide. Yeah, it's back now.
Let me see. Oh, yeah. So you start with correction of, if the patient is in shock, you correct shock. So you will give 20 ml per kg of normal saline. And if you're in a center where you don't have normal saline, you're allowed to use your Ringer's lactate. And you give these over around 20 to 30 minutes. And if the patient is still in shock, you can repeat the bolus, but do not exceed 40 millimoles per liter. Then if your patient is not in shock, you give your fluid at a dose of, it's a range 10 to 20 mils per kg. So 10 mils per kg over 1 hour. So after 1 hour, you want to determine how much fluid this patient will be on. And this is usually determined by one, the degree of dehydration, so severity of dehydration. So is it 10% dehydration? Is it 7% dehydration? Or is it 5% dehydration? So how do you calculate the deficit? Like the deficit is the dehydration. So if I say that someone is 10% dehydrated, how much fluid do they need? So you take the percentage of dehydration, which is 10, multiplied by a constant of 10, multiplied by the weight of the patient. So like for our patient who was 20 kilos, it is 10 times 10, which is 100, multiplied by the weight of 20. So you get 2,000 ml as the deficit of fluid. And then you cut, that is the deficit that you're supposed to replace. But remember, this patient, because they will not be feeding, they need to be on the normal maintenance fluid, that we usually put our patients on. So you calculate it the normal way. First 100 kilo, first 10 kilos, 100 ml per kg, next 10 kilos, 50 ml per kg, any weight above 20 kgs, 20 ml per kg. So now for the maintenance fluid, that is for 24 hours. So you need it for 48 hours. We usually calculate fluid for 48 hours. So you will multiply maintenance fluid for 1 day multiplied by 2 to give it 48 hours. Then add your deficit, which was 2,000. And then in the new guideline, you are supposed to subtract the fluid that you gave rapidly to correct shock. So you subtract the initial 20 times 20 fluid that you gave. And then you divide that by 48 hours to get how many mLs per hour. And if you are using, Soluset or the other giving sets, you can still be able to calculate in drops per minute, which will help you regulate the rate of flow of your fluid. I hope that is.
Yes, that is clear, I think. Thank you. So the question on phosphate supplementation. Yes.
Oh, there's a question on phosphates. Yeah. So usually during DKA treatment, there's risk of hypophosphatemia, and phosphate depletion usually occurs due to, one, there's urinary loss of phosphate from the osmotic diuresis that I had explained. Then there's also reduced renal tubular reabsorption of phosphate. And usually, when there's metabolic acidosis, there's a shift of intracellular phosphate to the extracellular compartment, meaning that the phosphate within the cells will be low, and also dilutional hypophosphatemia. Also, insulin administration also worsens the phosphate depletion. But when we manage DKA, actually, most of these patients who have this phosphate depletion, they do not have any symptomatology unless the phosphate level is very low, less than 1 milligram per deciliter, or what I would say 0.3, around 0.3 millimoles per liter. And in case you have a patient whose phosphate level is low, very low, less than 0.32 millimoles per liter, that is the time you are supposed to replace the phosphate. And what you can do is instead of giving potassium chloride as your choice of drug for potassium replacement, you can actually choose potassium phosphate instead of potassium chloride, and that way you will be able to have replaced the potassium and also the phosphate. And if the patient is getting very low phosphate levels, you need also to check, to monitor your serum calcium levels as you do the correction to prevent hypocalcemia. Thank you.
Thank you. So the next question is, for a child with resolving DKA, no vomiting, sugar stabilized, can they still be transitioned to subcutaneous insulin when urine ketones are 2+? Dr. Hewitt?
Okay, thank you for the question. Yes, of course, because after the patient is out of DKA, especially in the setups where you don't have BGA, it's difficult to know whether the patient is still in DKA or not, because even after a patient is out of DKA, the urine ketones can stay in the urine for above 24 hours. So if the ketone is trace or +1 in the patient is stable, actually you can transition to the insulin dose. Thank you.
Dr. Priska, are you still there?
Oh, sorry. I was muted and I was talking. So I was just saying, I was just adding to what Dr. Hewitt said, that remember that usually there's a lag in the urine ketones compared to the blood ketones. There's a lag of about 12 hours. So by the time you're having ketones of 2+ in a patient who has resolving DKA, the serum ketones have cleared. So if you have access to serum ketones testing, then it's recommended that you use that. We do not recommend using urine ketones to determine whether the patient has the DKA has resolved or not, but rather use the clinical symptoms. If the vomiting has resolved, they're able to take orally. If you're able to do a blood gas, if the acidosis has resolved, then you can transition that patient. So the next question is, there's an important question here, I think you need to address. There was a question on management of cerebral edema. Someone was asking if you could just summarize that on management of cerebral edema. Dr. Saumu.
Okay. Let me share the screen again. Yeah, so for management of cerebral edema, we said that once you suspect, as soon as you suspect cerebral edema, you must actually start the treatment. And how do you treat such patients? So one, you need to reduce your amount of fluid by 1/3. So you will give 2/3 of the fluid that you have been giving. Number 2, you need to elevate the head of the bed. And you need to give mannitol. Mannitol is usually the first choice drug at 0.5 to 1 gram per kg IV, and it is given usually over 10 to 15 minutes. And if there is no response within 30 after 30 minutes, you can actually repeat a second dose of mannitol at 0.5 to 1 gram per kg over 10 to 15 minutes. If you do not have mannitol and you have hypertonic saline, that is 3% saline, you can also use it at a dose of 2.5 to 5 ml per kg over 10 to 15 minutes. And also, if there is no initial response to mannitol, you can actually give hypertonic saline as your second. You give mannitol and then hypertonic saline. And also remember, as you are managing these patients for cerebral edema, make sure you've ruled out hypoglycemia. So you've checked your sugar, the patient is not having a sugar of maybe 1.2 that can, give deteriorating neurological state. And also think of other complications that may arise. So let's say, for example, you've given your mannitol, first dose, second dose, patient is not improving. Start thinking outside the box. Is this patient having maybe complications of DKA? And one of the commonest complications is thrombosis because you are in hyperosmotic state. So at that point, think of doing a cranial CT scan to rule out any thrombosis or any intracerebral bleed. Thank you.
Okay, thank you, Dr. Saumu. I think our time is spent. The questions are very many. We will take note of them and we will try and see how we can respond to them on a different forum.
Maybe
Yes.
Dr. Priska, I've seen someone asking, maybe you can respond to that, like patients who are on Mixtard, how do you transition them now after they are out of DKA? Someone is asking that.
Most of our facilities actually have support from CDAC, which is providing regular insulin and NPH. So we do not recommend transitioning patients to Mixtard. We're actually recommending that we switch them to basal bolus, which is easier to manage because Mixtard is a combination of 2 insulins, so it becomes very difficult to adjust the individual components. So we recommend that you actually transition the patients to regular insulin and NPH insulin, or if they're able to afford, then you can transition them to Lantus or Glargine insulin. Yeah. We will have a CME on routine care, and I think also Dr. Legong addressed this on the session last week on insulin therapy, which you should be able to access on the KNH Research portal, YouTube channel. So you can just refer to that for more information on insulin and the recommended insulin regimens. Thank you. So because of time, Dr. Saumu, I would like to request you to make your final remarks. Any parting shots?
So thank you, Dr. Priska. And I would like to thank everybody who joined us. I think we have gone beyond 1,000 participants. So thank you very much for joining. And my parting shot is for all babies who are coming to our facilities critically ill, always make sure you do a blood glucose at bare minimum. And if you find that it is high, always have a very high index of suspicion of DKA, because DKA is one of the leading causes of mortality among these children. And my prayer is that for all the participants who have joined us today, they will go back to their facilities and improve care in all children who have diabetes. Thank you.
Thank you. Dr. Hewitt, any parting shots?
I think it has been all said. Let's just try not to miss decay because it's very manageable case and we lose patients if we miss them. So as Dr. Samu said, at least the simplest thing we can do is measure the sugar level and act accordingly. So thank you for participating.
Thank you very much. Thank you, Dr. Hewitt. Thank you, Dr. Saumu, for an excellent presentation and discussion. For those who are asking about the presentation and how to get the slides, the presentation will be uploaded on the KNH Research YouTube channel in the coming days. So you'll be able to access this and the previous presentations we've had in the other webinars. Tomorrow we'll have a session on routine care, and we will continue with the series until 14th of November. With that, I think we can call it an evening. Good night.
Good night.